Massachusetts General Hospital in Boston, and I direct the adult sarcoma research protocols. I'm also a founding ex-president of the TAROS with Dr. Daniel Chen, and this is my fourth TAROS. Thank you for joining me this afternoon. I'm going to take you through sarcoma eContour and the current evidence for some of the practical aspects of sarcoma treatment, and I have no conflicts of interest. So I will devote the session to soft tissue sarcoma of extremities, trunk, and retroperitoneum, and the issues unique to sarcomas for contouring, starting from the CT simulation, the contouring details, modality choice, OARs, plan review, dose fractionation, and differences in pre-op and post-operative management, IGRT, and adaptive radiotherapy. I'll do the same for retroperitoneal sarcoma, and at the end, if we have time, I'll go over some special case scenarios involving a desmoid tumor, equimixal inflammatory sarcoma, superficial sarcomas, thoracic, scalp, and cardiac, some of the rare sites. So to start off, we have a 50-year-old, otherwise healthy male who presented to his PCP with a gradual painless enlargement of his left thigh for over 3 years. He has no history of trauma and recently noticed more rapid increase. Eventually, an MRI was ordered showing this 18 centimeter by 12 centimeter by 10 centimeter large heterogeneously enhancing T2 bright mass within the left quadriceps. The patient was referred to a sarcoma center a month later and reports a marked increase in the size of his thigh during this interim. So a repeat MRI was ordered after consultation. And this showed an increase in the size to 20 centimeter by 16 by 14 with multiple internal T2 low signal septations. So a CT-guided biopsy was ordered, core needle biopsy. So we have some interactive questions, and I'm going to do several cases in a row. The answers, there's no right or wrong answer. We want to see a distribution of how people might manage this. So I encourage you to participate. So if the biopsy turns out to be a myxofibrosarcoma, high grade, would you treat A, preoperatively 50 grade, B, postoperatively 60 to 66 grade, C, definitively to 72, or D, resect and then decide on radiation based on margins? Can we show the answer? Okay, so it looks like significant. Most of you would resect and decide on final margins, and then some would treat preoperatively a quarter, and then a quarter knows already wanted resect and definitely give postoperative radiation, and no one's going to just give radiation. Okay, so what if the pathology actually turns out to be a myxoid liposarcoma? Would you treat any differently? Would you do A, pre-op to 50 grade, B, pre-op to 36 grade, C, post-op to 66, and then D, resect, and then again decide based on margin? Okay, looks like again most would resect with a small proportion quarter treating preoperatively. And interestingly, no one chose B, which is a lower dose, and we'll cover this later on. So what about scenario 3, where we have now a different location, also in the lower extremity, 35-year-old female with an initially painless right thigh mass, ultimately underwent ultrasound and MRI showing the subcutaneous 5 centimeter mass lateral to the greater trochanter and vastus lateralis in a subcutaneous compartment. The biopsy demonstrated high-grade myxofibrosarcoma. So for this case, would you treat preoperatively to 50, postoperative to 60, that's a typo. C, resect once and then postoperatively treat to 60, 66, or stage a resection with vacuum dressing until negative margin, and then again treat with 60 to 66. Okay, let's see. All right. So pretty even split, actually exactly even split between pre-op to 50 gray. Interesting, some would treat to a lower dose, and then D, a third would treat with a stage resection until negative margin, and then boost, and then a postoperative radiation. All right. So the Sarcoma guidelines, which was published in 2021, pulls together probably the best current collection of evidence for indication, sequencing, dose fractionation, and target volume delineation guidelines, RT planning, simulation, and delivery for truncal extremity sarcoma and retroperitoneal sarcoma. So I highly recommend reading through the whole guideline and some of the supplementary data that was used in formulating the guidelines. So I won't go into this in great depth, but I will highlight some of the key recommendations. The treatment algorithm emphasized multidisciplinary evaluation for preoperative or postoperative RT for the initial management of localized primary extremity or superficial sarcoma. So first of all, as far as the indication for radiation in the treatment of extremity and superficial truncal sarcomas in adults, there's strong recommendation for multidisciplinary management. RT is strongly recommended for patients with high risk of local recurrence, anticipated closed or microscopically positive margin, but not for patients at low risk of recurrence. Preoperative RT is strongly recommended for most primary localized extremity truncal sarcomas for upfront treatment or following initial unplanned non-oncologic resection with a plan for oncologic resection. Postoperative RT is strongly recommended the patients who already have had the initial resection that's oncologic and did not receive any pre-op radiation, or patients who might have adverse features for wound healing for whom preoperative radiation is contraindicated. For example, in proximal lower extremity sarcoma in a patient who is diabetic or vasculopathic. And then for patients who have undergone an unplanned excision where additional oncologic resection is not feasible. And the recommendation is conditional for other features, such as a patient presenting with uncontrolled pain or bleeding or big fungating tumors. So you've decided, this is for the very first case where this turns out to be a deep myxofibrous sarcoma. You're now ready to perform simulation. If you've decided patient has no other risk factors, that you would go ahead and do preoperative radiation to 50 gray for this histology. How would you position the patient? Go ahead and vote. Oh, can we display the answer? Okay, all right, great. So 80% of you would frog leg the patient in a custom immobilization, and about 20% would do neutral, also in a custom immobilization, and no one would recommend doing just a low knee fix or a back lock. All right, and then next, for simulation, would you use IV contrast? Yes, always. Yes, if no allergies, or no. And again, there are no right or wrong answer, just to see what you would do. Okay, so I think vast majority would do, either yes always, and I presume if someone's allergic, maybe pre-medicate, or yes, only if no allergy, and a small fraction would not use any IV contrast. Okay, next. For simulation, would you wire the incision and drain? Okay, let's see. So vast majority would wire the incision and drain. Okay. We have a whole series of these to help you think through the steps. So next question. All right, and would you use a scrotal sling in this patient? You can see this is a male patient. So go ahead and vote. All right, so if we can switch back to the slides. Oh, sorry, so vast majority would use the scrotal sling to protect the scrotum, the testes. Okay, great, thank you. All right, so we'll go over what the guideline says. So immobilization is strongly recommended for reproducibility of accurate positioning for truncal extremity sarcoma, where variability in positioning for both upper and lower extremity is much higher than you would see for most of the rest of the body, trunk or head and neck, or CNS. And there is a recommendation to wire all scars, drain sites, no hematomas or romas. And if it's, just some practical points, if you do see an unexpectedly large collection of hematoma, it's important to confer with your surgeon. It's not unusual for us to be the one picking up a first wound infection or abscess, and that could then require that wound to be addressed before you can proceed with a simulation. And when possible, fuse with MRI and involve surgeons when in doubt if the location of the tumor is unclear or no pre-op imaging. So those are some of the things for post-op. So wiring incision scars, those are important. You also need to think about, in terms of the immobilization, and before you even talk about contouring, is how you position a patient. Do you put the patient head to gantry or feet to gantry? You need to scan this and plan accordingly, because the last thing you want to find out at the time of virtual simulation is the patient was treated for the opposite direction, and that would require a complete replanning. You also want to anticipate the modality of treatment that you might use, the potential beams and angles or beam arcs that you might need. And as part of that, they look at potential gantry clearance issues really, relative to the contralateral limb, or what I tell my residents is steric hindrance, about the only applications of organic chemistry that they have left from pre-med. Are there any entry or exodosis to the contralateral limb? Is the other limb going to collide with the gantry as it goes through the optimal angle or arc? So all of this is important as you plan what type of immobilization. And there are different types of immobilization: alpha cradle, thermoplast, vacuum bags, or more rigid modular or rigid custom immobilization. These are all important. So Colleen, Dickey, and others show that it's very important to customize the immobilization for extremity sarcoma patient. On average, you save about 2.5 minutes or 2.2 minutes with custom immobilization, and reduce an uncertainty, and can reduce the PTB by 2 to 4 millimeters in all directions. It's important to immobilize the joints, movable joints, proximal to distal to the treatment field and borders, and also should make sure that the immobilization does not increase the surface dose and does not end up having a bolusing effect. So these are examples of immobilization. Pardon me. So this, for example, is a indexable bar on which then something very similar to a mask where thermoplast is used. So kind of the similar to what the intracranial mask, and then that forms a customer over this patient's foot. And so that's what's used at Princess Margaret Hospital. This is an example of another type of kind of modular, but customizable to a patient to some degree from a group in China. And then using various forms of immobilization. This is using kind of more of a vacuum lock, but combined with thermoplast lying over that. Here's an example of a frog leg position. And here a very long wiring of the incision. The authors show that is using custom immobilization or vac lock back. The key thing is having rigid enough of immobilization to limit the main points of movement, and both result in reasonable reduction in the systematic error and random error. And therefore, the PTV can be adjusted accordingly. Without rigid mobilization, the PTV necessary may be over a centimeter. So other important things to keep in mind for CT simulation for the lower extremity, whenever it's possible, you want to keep the treatment leg neutral, except when you're treating more proximally near the inguinal, where you may need to frog leg to decrease the skin fold or perhaps reorient the location of the tumor such that you have better beam angle options. For the more distal and relatively centered, like lower leg sarcoma, you need to displace a contralateral leg to avoid exit or entry dose. And it's relatively easier to do for the lower in the leg, like the calf or pretibial area. If you're doing VMAT or IMRT, you need to check if externally rotating the treatment foot might help shift the target volume into a more optimal angle and avoid having to move the contralateral leg altogether. And then sometimes 3D is a bit more rigid, and so sometimes you may need to elevate the treatment leg on styrofoam or elevate the contralateral knee, sometimes fully flexing that to get it completely out of the way. For the feet, if you're treating the dorsum, consider slightly plantar flexing it. And then for plantar, you might consider treating the patient's prone. So I'll show some examples of this in a bit. So for upper extremity, arm mobilization, you want to decide, is it better to pronate or supinate the portion that you're treating? Sometimes the best position may be somewhere in between with the thumb pointing vertically. Upper extremity often have to be positioned with the treatment arm elevated above the head in what we call a swimmer position with the face down, or akimbo to get it away from the body. And if you decide to keep it akimbo, just be sure to bias the patient to the contralateral side so you have plenty of room for the treatment arm. And sometimes you may need to elevate the treatment arm at the best angle so that the best angle or arcs might not clear the body if the arm is down too posteriorly. So you want to elevate it up to make sure you have the best angle possible. For the shoulder, the position can be highly variable using just these immobilization boards. So something that comes over the shoulder may be optimal. So sometimes a kind of S-frame type of long mask may be the best. Or if you do use some sort of mobilization like back lock back, having thermoplast that prevents the shoulder from elevating, from rotating, from just a highly potentially variable area. For hands and fingers, you want to immobilize the digits not being treated out of the way. So you need to visualize the potential beam angles that you need to use right at the simulation, right even before the simulation, right at the immobilization. All right, so examples of mobilization. Basically, you want to see, as you're seeing a patient in consultation, assessing what kind of plan you might need to use. You want to almost visualize what that plan is going to look like already and immobilize them a certain way. So here's an example of elevating the contralateral leg on some styrofoam and the treatment leg at the knee, and then at the foot there's rigid immobilization. So kind of controlling all the potential angles and then considering the best way to get in the arcs without exiting to the contralateral side. This, for example, is this is actually very similar to our first case patient, where it's a medial proximal going. So here we have the leg frog-legged, again controlling kind of the angle at the knee, at the hip, and then a scrotal sling, as you can see the patient here. We ask the patient to help with that process, and that protects the scrotum out of the way. So you want to essentially visualize the best beam angles. And here's the eventual beam with the scrotal sling pulling to the contralateral side, the beam arrangement with no exit to the pelvic structures or the contralateral thigh. Here's an example of a hand where in this particular case, the patient basically has the arm elevated above, and you can see that rigid immobilization for thumb and the palm getting as much as possible out of the way. And so again, what you see is the MRI, but you want to start to visualize what type of beam arrangement you want to do. And so here's another example, supine, the arm supinated with a bolus built into the immobilization. Because remember, you won't be able to see the plan and decide you want an immobilization for adequate buildup for a finger or toe sarcoma, and be able to squeeze that under the foot or the fingers after the fact. So you want to start to think about do I need that dose buildup? Where do I need it? And it turns out the company that sell the immobilization, the thermoplast masks, like those little donut holes that are punched out, you can buy them back in big jars, and you can heat them up, and they're like putty, and you can use them to custom make these rigid immobilization, build them right into the immobilizer. Okay, so just a couple more examples. Okay, so overhead for someone who being treated with the optimal angle for the forearm requires this clearance away from the body. Here's a foot, so a slightly plantar flex. We're treating this one for the plantar aspect, and then this one slightly. Again, this one is more suitable for a supine position. So it's just really very much customized for each patient. All right. So for the scan parameter, you've made the mobilization. It comes over to the C2 simulation. You want to be sure that you scan adequately. So these are all different things we either learn from experience or have found out one way or another to be very important, and you just don't want to have to go back to that step, 2, 3. So you want to make sure you include the next joint beyond the involved area, because you need that longitudinal information for portal imaging to see where you are, and also just having adequate margin for extension for your CTV and PTV. For postoperative cases, you want to wire all scars, biopsy sites, or known hematoma. These are potential areas of tumor seeding. At least the current evidence that I'll go over in a bit doesn't suggest it's that we're ready to shrink down the post-op target. You want to keep in mind the CT board. I think a lot of departments probably have whiteboard now, but this used to be a big problem for some of the 60 cm CT boards. You need to be very aware of where is the limb relative to the edge of the board, and are you going to get that in the field of view? Any metal fasteners that it's part of immobilization should be outside of the treatment area to avoid artifact. And so this, the IV, so the question on IV, although it's not specifically in the sarcoma guidelines for 2021, and the use is variable, I do find that it's valuable in cases where the patient is not able to get an MRI. That tissue definition is extremely helpful. All right, next question. So what CTV margin would you use? A, 9 centimeter longitudinal, 5 cm. B, 5 cm longitudinal and 3 cm radial. C, 4 cm longitudinal and 2 cm radial. D, 3 cm longitudinal and 1.5 cm radial. Or E, 2 cm longitudinal and 1 cm radial. We'll use the high-grade myxofibrosarcoma intramuscular case, pre-op case for this. Okay, let's see. All right, so all you would use somewhere between 3 to 4 cm longitudinal and 1.5 cm to 2 cm radial. So basically, kind of U.S. and Canadian margins. All right. So the target volume. Let me go over this. So the current target volume, the one key thing is to, no matter what you do, whether preoperative, postoperatively, that this is anatomically constrained. And I'll go over what that means. But the guideline more specifically goes over these margins. So for preoperative case, you want to use define your GTV well, using that best with contrast if you can, or MR. Define your GTV well, and then from there you want to do a 1.5 cm radial expansion and 3 to 4 centimeter longitudinal anatomically constrained expansion, and that means stopping at bone if there's no bone invasion, respecting the major compartmental fascia, unless there's been breach of that, either through an incisional biopsy or the very rare case where there's bifascial involvement. Those are extremely rare, but you want to make sure that you constrain this and do not unnecessarily expand into the subcutaneous tissue for an intramuscular case. Conversely, if you were treating a subcutaneous tumor, and this is very important, you want to be sure that to confine your CTV to the subcutaneous compartment. You don't want to just do an auto expansion and treat all of that deep muscle. So you can actually constrain your radial expansion to just 0.5 to 1 centimeter into the underlying non-involved muscle. And the reason is that deep fascia, which separates subcutaneous tissue from your deep muscles, should be a good barrier unless the patient has undergone a procedure where that's been violated in some way. And so there's no reason to go 1.5 cm, 2 cm, and you add another 0.5 cm or 1 cm to PTV, you're going to end up treating that whole muscular, that muscle compartment. So subcutaneous is very important to do that. And then the other important thing is in the subcutaneous tissue, your longitudinal margin, high-risk margin, is actually equal in all directions of that subcutaneous fat. I always tell my residents that there's no difference between fat cranial-caudally and fat circumferentially. It's all easy path of for spread. It's a tissue of low resistance. So you end up with more like a pancake-like volume that's just in that subcutaneous space. For post-operative target, you want to define the tumor bed with clips for preoperative MRI, seroma, plus a 1.5 cm radial and 3 to 4 cm longitudinal margin. In addition to that, add the operative field, surgical scar, and drain sites when feasible. And then that typically goes to 50 gray, and then you come down to just a tumor bed plus a 1.5 cm radial and 2 cm longitudinal margins for the additional 10 to 16 gray, depending on the final margin. For subcutaneous post-operative tumor, it's the same concept. The key thing is just, again, to be sure to be aware that that tumor bed in the subcutaneous area is much more than meets the eye. It's not just the incision with a small 2 cm strip along each side and 3 cm supinate, and I've seen that, and I've seen tumors recur to either side of such a long volume for subcutaneous space. So I think subcutaneous myxofibrosarcoma in particular is so infiltrative it's underestimated. So this is actually a very important point. And so those patients really recur much more than you might expect for being a superficial sarcoma. And then lastly, the PTV expansion can be 0.5 if there's daily imaging. However, if there's no daily imaging, especially if there's not rigid immobilization, then you may need to use greater than 1 cm. And those initial days of, the initial port films are going to be very important. If you see even, whatever you've decided on PTV is inadequate, then you need to go back and say, do we need a more rigid mobilization? Do we need, more close imaging? Better, more imaging if you're not doing daily guidance already. And then lastly, the dose coverage for PTV can be trimmed back 3 to 5 millimeter from the skin because you don't want that full dose to the skin unless a tumor is directly at risk of invading the skin. And so it's okay to reduce that PTV with a rim from the skin. All right. Okay, so can we reduce the postoperative volume? I referred to this a little bit. The Vortex trial which has finished, and at no long-term follow-up. It was reported in ASTRO 2016. Was a multi-center trial to see if you where patients were randomized to a standard arm, 50 gray to the 5 cm craniocaudal and 2 cm radial margin, and then combed down to 16, versus the experimental arm where all the patients were treated to just GTV plus 2 cm margin. So smaller margin, not chasing incision or drain, and they were looking for a primary outcome of functional limb function at 2 years. And 216 patients were enrolled at median follow-up of 4.8 years. And they saw the patients didn't have any significant difference in terms of their functional outcomes. The local recurrence was comparable, and no difference in the late-grade toxicity. So they didn't observe any apparent difference in the limb function between the two. And they felt the study was ultimately underpowered to show any difference in the local regional relapse-free survival. There weren't many events, but both were a little bit lower than what we currently think of kind of the more contemporary results for local relapse-free survival, around like 90, 95%. So this warrants further up, and the general feeling is that it's not yet conclusive if you can reduce postoperative volume to these tight margins. So currently the standard is still going 50 gray to the larger 5 cm type of margin. It's basically 3 to 4 cm plus the additional PTV, getting you up to that 5 cm. All right, volume definition. So a bit more specifics on that. Fusion with MRI if it's available, T1 post-GAF for GTV. T2 is important to look at peritumoral edema for inclusion. It's important to look at each case and know what compartment and muscles are involved. The art is in the CTV, so do not auto-expand along the XYZ of the couch. It's non-anatomic, but we certainly sing it a lot, doing like QA for NRG, RTOG sarcoma trial. This was something we see, you can tell if something is an auto-expansion. You can over-treat or under-treat true anatomic planes of invasion doing auto-expansion. So what I recommend is that once you define a GTV, then you create expansion guideline to show you in spheres what is 1.5 cm, 2 cm, 3 cm from the GTV edges. And you start right from the middle of the tumor, where you can see the tumor best, contour the CTV in an anatomically constrained fashion all the way to the cranial end, and then come back to the middle, draw it all the way to the caudal end, what these established guidelines of, and based on what you understand of the patterns of local spread. Do not cross anatomic barriers unless surgically violated, and so this already mentioned. Okay, so this particular case that we just saw, this was involving the anterior compartment of the leg, and so an anatomically constrained CTV would stop right here at the bone, but come up, to the edge of the fascial compartment. Here, sorry, this doesn't show it well, but you can stay, basically about 5 millimeter past the fascia overlying this muscle, because the patient just had a core biopsy, no violation of the subcutaneous space. And then when you subsequently then add the PTV, again, you can constrain this superficial area in the subcutaneous area, and then you add that 5 millimeter with daily image guidance. All right. So this just shows you why it just doesn't make sense to do auto expansion. If you have a tumor in a muscle going in this direction and you're auto expanding XYZ, you end up over-treating this area, under-treating the high-risk longitudinal spread. And so I really don't use the word sup and inf. I really use high risk versus low risk, or longitudinal versus radial, to reflect that sarcoma infiltrates more readily along the path of least resistance and generally stop at these natural anatomic boundaries. It's also important to know that not all compartments, in fact, most compartments are not just ellipsoid. So it's important to know the origin, insertion, or the beginning of a compartment, the end of that compartment. And so, for example, in most unless you're dealing with one of these longitudinal muscles where maybe an XYZ expansion would be fine, but if you have one of these muscles that's going off on the diagonal, gluteus maximus, latissimus, trapezius, deltoid, you want to be sure that you're expanding along the axis. That makes sense. So I'll skip over the talks on the margin. This is well detailed in the guideline, and these are hopefully well known to those of you who treat sarcoma. There's no randomized control trial for margin for soft tissue sarcoma, but through the NCI Canada randomized trial of pre-op versus post-op radiation, and then the RTOG, the North American or U.S. study, 0630. That's where we get the current margins of 3 to 4 cm. Longitudinal and radial, and basically with IGRT and these modern margins, the late effects are reduced compared to what was seen with the earlier era with these 5 to 9 cm or even whole musculoskeletal compartment type of volumes that were used in the early days of pre-op radiation. All right, and one nice thing that came out of RTOG 0630, which is we think of it as our contemporary IGRT, modern margin, preoperative extremity sarcoma trial, was also a series of consensus atlas put together by sarcoma radiation oncologists, and developing a consensus on how to contour the CTV itself and how to account for T2 edema in the CTV. And what we found that the inclusion T2 edema is highly variable. So some examples of this, for example, you see there's a very significant amount of T2 changes, even far away from the main mass. So you do need to use some clinical discretion. Some histologies are going to be a lot more infiltrative, like myxofibrosarcoma or aqueous myxo-inflammatory fibrosarcoma, desmoid tumor. It's benign but very infiltrative. So in some of the histologies, those T2 changes are likely very real. But currently, we don't have more granular imaging to guide us. And the pathology studies have demonstrated most of and this is where the Canadian 4 centimeter margins comes from pathology and MRI correlation. Most of the tumors that are away from the visible, MRI mass is within about 4 centimeters. Very few beyond that. All right, for post-op, again, you want to see that seroma. So, the original GTV, typically a seroma is going to be a bit bigger than that. Sometimes it might not be. So it's important to try to define that. If possible, surgeon, might have clips for you, that they've placed. But you also want to use that pre-op MRI to guide you. So you don't end up with based on just the incision or the small, retracted seroma, a smaller tumor bed than it actually should be. And then again, anatomically constrained to the bone, to the subcutaneous tissue. All right, so this is an example of that. This is the plan for that young lady with the subcutaneous myxofibrosarcoma after having undergone stage resection to get a negative margin. And then here's kind of a fusion with a pre-op volume and then the post-op stromoma, ultimately creating a target, a subcutaneous target that goes along this fat. And in fact, you can see from here, it's about 3 to 4 cm in the circumferential fat as much as it is supinative. Okay, no difference in the fat in those directions. And then this is an example of an elbow, subcutaneous myxofibrosarcoma, again, resected to negative margin, and then treated with this pancake-like, target volume, and this is where IMRT is really, really nice for it. You can also see in this case a patient does have the arm up and away because closer body was just too akimbo. All right. So, all right. Lastly, so what modality would you choose? So you have the interactive. So 3D protons, IMRT, VMAT, brachytherapy, protons or electrons for this patient with the deep sarcoma. Okay, so most would choose IMRT VMAT, and some would use protons. So that's actually, pretty good. If this were a young man or that's actually a young woman, that proton actually be very reasonable for this very proximal sarcoma. But yeah, I think in most cases, the VMAT would do a pretty good job, and 3D would have a harder time with this location. All right, so you could go back. So, so IMRT, and I won't go into this in great detail, but nice studies from Brian O'Sullivan, Princess Margaret, showing that IMRT, acute complications pretty similar to other forms of pre-op radiation, but late toxicity is significantly improved compared to the NCI, the previous pre-op, post-op. So the complication rates are down in the kind of 5 to 10% range. And then if there's a wound overlapping with the PTV, where the flap, the planned flap overlaps, that predicts for wound complication. But there was no compromise in local control with the tighter margins, use and tighter doses with IMRT, more conformal doses. All right, and this question, would you use bolus? Yes, always, only if CTV is not covered by 95%, only if tumor had been previously violated, or never. Okay, let's see. All right, so split only if it's not covered well or it's been previously violated, and some would say never use it. All right. So in the guideline, the routine use of bolus is not recommended unless the clinical target includes the subcutaneous tissue or skin, dermal involvement, ulceration, et cetera. So, all right. So, and the exception is, in the fingers and hands that I mentioned before, where it would be hard to add on, and you need more for buildup, anticipate more for buildup, and again, very judicious in use of that. So you want to anticipate all that right from the get-go. All right, so doses, skip that. And evaluating a plan, it's important to start with the ARCs, look at the bolus, look at clearance issues, the dose coverage. And then lymphatics, there's no recommendation to cover elective nodal radiation for the very rare lymphotropic sarcomas, clear cell, angiosarcoma rhabdoepithelioid. All right, so what bone constraint is currently considered standard? My last question, sorry. A standard, this one does have a right answer. So A, V50 less than 50, max 60. B, V40 less than 64 with a Dmax 59. Or B, 30 less than 50%, Dmax of 45 or no constraint. Right. So let's see. Yeah, most of you, most of you got it right. So we do have evidence for this, and this was back from actually pretty long ago now, from Cancer 2010, where fracture risk is to minimize the risk of fracture and to keep the V40 to less than 64%, mean dose of less than 37, and Dmax 50. And then more recently at Memorial Sloan Kettering, if you apply those constraints using IMRT to force the dose out of the femur, the patients have only 1.8% fracture risk compared to 7.4%. So it does pay off. All right, daily IGRT. I mentioned. All right, sorry. So during pre-op radiation in sensitive histologies where the patients will undergo induction chemo, where they may be pseudo-progression or shrinkage of tumor, it's important to do daily imaging and check if they need adaptive planning. So there are studies that show histologies like myxoid liposarcoma are especially like to shrink. And so you can have very significant regression or progression. And so it's important to do that IGRT. And catch changes. All right. So I think I'll stop there. I think the only thing to mention is myxoid liposarcoma did recently have a study that showed it's okay to reduce the dose to 36 gray because it's exquisitely sensitive. This is a do-re-mi study, a nicely named study. And then just saying that hypofractionation is coming down the line for sarcoma. Tissue definition, is going to be even more important, I think, with these larger fractionation, although they currently haven't shown any major differences in acute toxicity. Late complication is still requires much longer follow-up. And so these guidelines are important to keep in mind. I think we're all out of time, so thank you for your patience and participation. Burning questions? You want to just ask directly?